we go. All right, so today we're going to talk about oral surgery in a COVID environment. Part of it is going to be how to reduce aerosols, but that's not kind of all of it. It's just how we're kind of working in this environment. Part of this will definitely overlap with what we've heard from previous presentations on PPE and such, and we're going to be referring a bit to the CDO's directives, all those communiques we've been getting that tells us about stuff. This is current as of now, but this will be streamed on YouTube or something like that, I think. So keep in mind what you see here might not be the most current data, so be sure to check up on it if you are going to be using this as your reference. All right, today we're just going to go over a few definitions, which I'm pretty sure everyone's already going to be pretty solid with. We'll talk about where we're at and what we're aiming to do and what we're going to do about it. All right, everybody knows about aerosol generating procedures in the field of oral surgery. That basically comes down to using the drill or irrigating. Protective measures, we're going to talk about what we're going to do for that as well, but basically those are mostly directed by the CDO. Basically avoidance, using a mouth rinse, including hydrogen peroxide or something. Chloroxine doesn't seem to be as effective, so we're trying to avoid that right now. And then COVID, SARS, if you haven't heard about that yet, check the internet. All right, now this next one is an excerpt straight from his interim directive, droplet transmission. So basically these are big chunks of fluid that contain the virus that can sit on surfaces, and they take a while for the virus to die in it because they stay moist and nourished. It can be days while they're still infectious. This is also what's going to be on the outside of your PPE, which is why it's really important when you're taking off your gown and your gloves and your mask and all that stuff to be touching the inside of it, not the outside. There were some really good videos that put out earlier that you can see on YouTube, so I would check those out if you're at all confused on how to do that. Aerosol transmission. Sometimes when people cough, they can generate a little bit of aerosol, but it's not really considered to be a huge concern with COVID. But when we get our drill in there, we're taking saliva where there's definitely stuff and we are aerosolizing it, which is why we're avoiding all those aerosol generating procedures. All right, so we know COVID's out there. We know there's community spread, so there's a bunch of unknown vectors out in the community that are spreading it without knowing it. We can't track where it's coming from at this point. So earlier on, it was a little bit helpful to do the contact tracing. Now that's helpful to find a positive, but it is not helpful to rule out a negative. So there's a lot of carriers out there that never show symptoms, so just be aware of that. And we still do our screening, but that doesn't guarantee our safety by any means. All right. Another part of the situation is that our patients are still breaking their teeth. They're still getting cavities. They're still hopefully not getting in bar fights or anything like that, but they're still encountering some trauma. So patients still need to be treated. Another situation we have is that we have the PPE we need, but we don't have unlimited supplies of it. So we got to be considering the proper usage of it to make sure that the people we see today don't hinder us from seeing people in the future that might need it more than they did. All right, so first off, we've got to figure out what the problem is. We've got to treat it, and all in the while, we're going to try and minimize risk, both for communication between patients and staff, but also being a nidus for disease in the community is something we want to avoid at any cost, because dentistry has the potential for that, which is why we're working with such high level disinfection, IPAC, PPE, and all that stuff in order to make sure that never happens. Now, can we do all of that, or do we have to compromise in one of those categories? Well, what can we do about that? We can screen our patients like I talked about. Some of our patients can be treated with teledentistry. I know we're doing that with a number of our screenings we're doing in Petawawa for deployment now. People that call in on sick parade, we're doing a lot of that over the telephone as a first line. If they're calling in because their teeth just aren't white enough and they need an emergency bleaching, well, they're probably gonna have to wait for that. If they got a little chip that's a little rough to their tongue, they might have to wait for that too. But if they've got a giant abscess threatening their airway, we're gonna treat that. Limiting contact, maintaining physical distancing, that could be anything from keeping a distance from the patients, letting them sit 6 feet apart in the waiting room, having them sit out in their car and calling them on their cell phones to bring them in instead of using the waiting room at all. All those things are stuff you can decide on locally what's best for you. Proper PPE, that is not an option. That's something that we're going to have to do. And we talked about the limitation of aerosols, which is what we're really looking for. So we don't understand everything about COVID. We didn't really know much about it at all till last fall when it started popping up in China, and we are learning a lot about it. We know a lot of the basics, but a few of the fine points I'm sure are going to change over time as we've seen changes over time. What PPE is considered effective? We've seen quite a change over the past few months, what's going on to wanting us to be masked when we're out in public, as well as just when we're seeing patients. Testing. One of the ways we could really get around this would be to do a rapid test where we can diagnose someone that morning, whether they have COVID or not, then we can proceed with their treatment, not having to worry about whether they're a carrier or not. We're obviously not there at that point, either with the development of those tests or the deployment of them. So as that develops, obviously that's going to change the way that we do things. All right, so normally when we're talking about taking out teeth, there's a whole lot of reasons that we can do this. All good reasons in certain situations. In this environment, there's a lot of reasons in here that we're not really in a rush for. We're not prepping people for orthodontics. We don't really care too much about pre-prosthetic stuff because we're not doing anything there. We'll eventually find a way to get back into these as time develops and we come up with mechanisms, but only the most severe cases are what we're really considering at this point. The Chief Dental Officer has helped us out by giving us some pretty good guidance. Under the emergency conditions, those are the things that are going to kill people. Those are usually done at the hospitals, likely by a surgeon. The urgent dental conditions are what we're seeing on a day-to-day basis in our clinics, either via the telephone or in person. Severe dental pain, pericornitis, all these things are things that need treatment if you can't deal with it more conservatively. So we're going to talk about that in just a little bit. All right, so when it comes to surgery, basically limiting this lecture to the extraction of teeth. One thing you're going to have to do is determine the level of difficulty, because that is just a baseline that you're going to need to know before you can go any further with your planning. So everything that you see, well, you either get from the information from the patient, such as the subjective information on the telephone or an in-person interview, your objective findings when you did a physical exam, as well as any relevant tests such as x-rays, Panorax, PAs, or anything along those lines. We're going to take a look at all aspects of the crown, the roots, the surrounding alveolus and periodontium. And then depending when you put all that together and you determine how difficult you think this is going to be, you can decide what you want to do. Do you want to extract it? Do you want to do some alternate treatment? You're going to do a root canal on it, which might generate some aerosols, but with a rubber dam, disinfection, and so on, it's going to generate smaller levels, especially if we're still using the high-level PPE. I know I wouldn't want to have a tooth taken out if I didn't have to, but if you have to, that's kind of what we're here for today. And then also referral is always an option. Anyone that works at a specialty care center, you've got surgeons. Other bases might have people with various levels of experience, whether it's a periodontist, an AGD, or just a dentist that's done the surge course or a lot of extractions. Use the resources that are available to you. So either contact someone at your own base or talk to one of us remotely if you just want help with this stage. Once you've determined how difficult it's going to be, especially if you've decided that you're going to be the one proceeding, you need to figure out what your setup's going to be. Do you need low-level or high-level PPE? What instruments are you going to want out? Are you going to set up a drill or not? Are you going to set up different elevators or not? You need to figure that out all before you get started. All right, so here's a few examples of things we're looking at when we're trying to determine the level of difficulty. The risk of an ORO-ANTRAL fistula, sinus proximity. I would love it if we got this nice of a view on our Panoraxes, but unfortunately we're getting a 90-degree image where it's just coming in from the side. In a case like this, where we're taking a look at the Panorax, I would be highly suspicious that we're going to end up in the sinus if those roots aren't already in the sinus. So proper examination and diagnosis before you get started is really going to make things a lot easier on you. Taking a look at the restorability of the tooth. We've got a large crown, we've got a post, we've got endo, we've got an apical lesion, we've got potentially something going on with the root in this area. Dilacerated roots, crumbled, decayed, restored crown. I mean, there's a lot of things that we're going to have to look at to decide, is this something that you're going to be able to handle on your own? Some stuff that can be nice. You see a big widened PDL space, that might be a little bit easier to take out. No. On the other side, we've got this pediatric tooth. You might look at that on a regular basis and say, oh, I'm just going to split the tooth in half and lift it out. Well, if we're trying to avoid the use of a handpiece so we don't generate aerosols, this is a very difficult tooth to get out. I'm not quite sure how that would work without a drill, because you'll see the two adjacent teeth have collapsed on top of it, so we don't have a path or access to get that tooth, that crown out of there. So on top of that, there's the dilacerated roots. So figuring out that difficulty before you put your PPE on, before you open it up, is going to be essential. Taking a look at this tooth, massive caries, very little crown. What's normally a good handle to grab onto the tooth with so that we can get it out from where it's firmly attached in the roots, all of a sudden becomes more of a liability than an asset, and very difficult to get that tooth out of there if you're not anticipating that crown's weakened. Big restos on the teeth next door. If you get a little bit of a wiggle next door, something that you figure might not be a very big deal, that restoration might be just ready to go. So beware of that too, and potentially have some restorative material in there if you figure the tooth's leaning into that one and it might cause you a problem. Well, the answer is to always just never break it, but good in theory. Taking a look at the x-rays, you might say, oh, look, there's a nice central incisor here. I can take that out without worrying about an x-ray or worrying about anything, without seeing the dilaceration of that root. We want to make sure that we get a good diagnosis so that we understand what we're getting into. It's not that that tooth can't get taken out. It's just considerably more difficult than the adjacent tooth right beside here. Taking a look at the root of this premolar, you might say, well, that doesn't look quite as easy as I thought. Little proximity to the sinus up top, severely bulbous root, especially if the bone comes over and there's a narrower aperture than can come out the bottom. That is something that will significantly increase your level of difficulty on that one. Another example here, you'll notice there's a lucency in the root of that incisor. Not a whole lot of structure connecting the apex of that tooth with the crown. You try elevating or using a forceps to get that out of there, you might notice that it separates there really easy, and then you've got something a little bit more difficult ahead of time. Once again, planning saves you a lot of effort. All right, so we've looked it over. We've come up with a diagnosis. We've decided that we want to do something with this tooth. What can you do? The directives from the CDO indicate that they want us to be as minimally invasive as possible. So starting with non-surgical treatment, pharmacotherapy. If they've got a 3 out of 10 pain, give them some ibuprofen, some Tylenol, manage them till we have PPE stocks in the clinic. If we've got these air evacuation units that are supposed to be deploying out to us all, there may be a reason you want to wait, or there may be a reason you want to go ahead. If there's an abscess, you're going to want to do an incision and drainage. You may choose to save the tooth, possibly in conjunction with a root canal therapy or a debridement of the root if it was a perio abscess. Temporary restoration. If this is a pretty carious tooth, you might decide you want to throw in a temporary Fuji or something like that, silver diamine fluoride to arrest the caries, and then plan for your extraction at a later time. Because you can either, if you're deciding you're doing the extraction, you can decide to do it right now, or you can decide to do it later. That might be when you can get some backup in the clinic, when you can get a hand piece brought over from the satellite clinic or something like that, if you've not got all your equipment together. But I wouldn't jump into something without the proper equipment or the proper plan. Then there's always the option of referring the patient. Much more complicated when we don't want people to travel and spread potential disease. But if you're in a larger center where there's someone else that you can refer to easily, or there's someone locally civilian that we can do that, those are options as well. All right, so as I mentioned earlier, make sure we're following the latest science, which hopefully the directives are coming out in a short order fashion as the new research comes out, so that we can be proceeding in the best manner. As mentioned, this is a screenshot in time of where we're at. Once you've decided that you want to do an extraction, try and make your best determination. Will this be an aerosol generating procedure or not? The more experience you have pulling teeth, the better an idea you're going to have. If you are just getting started, you're sometimes surprised by how long or how fast these extractions take you. I would probably err more on the side of an aerosol generating procedure. So that would be the setup where you're donning the N95 and the high level PPE. If you say, oh, this is super simple, I've done 1,000 teeth like this and I know it's going to be simple, then you can just go ahead and set up as a low level PPE. So important things, make sure you're screening the patient appropriately first. So here at Petawala, when we're talking to patients on the phone, we do a full COVID screening on the phone. We do it again at the front door, and you may or may not choose to do it again in your bay. It is not uncommon for people to give different answers to different people, so redundancy isn't a bad thing. Just because someone's been asked once doesn't mean we don't ask them again. They might have forgotten. We want to make sure that we're fresh and getting all the information. If they're symptomatic, if they have a probable exposure, if they're possibly or probably infected, those people shouldn't be coming into the clinic at this point. They should be getting treated elsewhere. Our current directives are we're not treating any of them in the clinic until that changes. Make sure that you've done a good screening process to make sure we don't accidentally let them in. If we contaminate our staff or we contaminate our clinic, the clinic's easy to clean, but a potential exposure is obviously going to keep you out of the commission for 2 weeks, which could be very detrimental to other patients' care. So determine what's going on, and then you can come up with a game plan for your patients that have COVID or are suspected to have COVID. For preparing the patient, the oral microbial rinse, we're using hydrogen peroxide ones primarily. If there's something else that's been published, that's fantastic. But decreasing the bacteria or the viral load in the oral cavity is good. Unfortunately, for extractions, you can't really use a rubber dam, which would make things considerably safer, but just ineffective in this situation. Making sure we have the proper PPE, which includes having the patient have a mask for before and then a mask for after the procedure as well. Laying a gown down over them or some sort of a drape so that they don't get contaminated with droplets during the procedure. Make sure you have the proper PPE. That's all from the directives from the CDO and from the FAQs that have been sent out. So when I'm looking to extract tooth on a patient, I am very cognizant of the patient's positioning. For a maxillary tooth, I usually have them laid down pretty much flat. For a mandibular patient, they're sitting up about 35, 45 degrees for me. And I get into a comfortable position, elbows by my side, hands at my front, nice and level. I don't have the patient right up at my face, so I've got little T-Rex arms. I find that people with less experience are more willing to accept wherever the patient happens to be and are going to contort themselves and twist themselves around in order to do that, which is going to be really bad for your ergonomics, your back, your neck, and the longevity of your career. Also, it's going to make it less effective. You're going to have poorer visualization, poorer light, and it's going to be harder for you to take the tooth out, which may make it so that it's not possible for you to take it out anymore. So patients are very understanding about tilting the head this way and that way. Make sure you're communicating with them while you do it so they're not shocked, but that makes it considerably easier for you. All right, so the basic steps for extraction of a tooth, whatever soft tissue attachments are, we're going to release them. So that could be periosteal elevating or raising a flat. We're going to reduce the periodontium's retention of the tooth. So the alveolus, the bone, PDL, basically we're going to stretch that stuff out and try and make space so that it's not held onto the tooth. So when I've got a forcep on and I'm initially starting with the tooth, I'm not pulling extrusive forces on it. I'm actually pushing into the bone and trying to widen that space so that I can later get that tooth out of there. If necessary, removing the bone, sectioning the tooth, whatever you need to do to make sure that there's less hold when we're trying to pull the tooth out. And then finally, removal of the tooth either in fragments or in toto. If we need to clean up the site, any alveoloplasty, curettage, and then afterwards clean it up and close it if necessary. So here's our tooth. If they all look like this, it'd be pretty easy. Nice wide PDL, nice conical shape. This is ideal. It shows you the soft tissue attachments at the top, the bone holding onto the roots, and then the ligaments on there as well. Obviously a little exaggerated, but that's what we're working with. Now, I am huge on the use of a pharyngeal screen. A lot of the times, bits of tooth break off, either when we expect it or when we don't expect it. The tooth can slide out from a forcep, much like you're squeezing a watermelon seed, and it can fall into the mouth. We do not want the patient, obviously, to swallow it or inhale it. So having a pharyngeal screen there, I'd say, is a baseline that you should always do. So when we're starting with the soft tissue, some people like to use a 15 blade going around, some people just use a 9 molt. As long as you get nice, clean release of the tissue all the way down to the bony crest. I want full soft tissue to bone with no soft tissue attached after I go through and I do that step. So firm pressure. A lot of people like to do a zigzaggy motion where they lift up, push down, lift up, push down, lift up, push down. That creates little saw teeth where there's still soft tissue attachments and tears as well. So what I generally do is I push down with my periosteal and I slide around one side, I push down with my periosteal and I slide around the other side of the tooth. Boom, it's done in seconds, not minutes, not hours. It should be a very fast portion of your procedure, under control so that your instrument doesn't slide, obviously. All right, elevation. I am big into elevation. Some surgeons are more into forceps, more into elevation. I try and do everything with elevation if I can. I find I have good control. The downside is that it can apply huge amounts of force, which can either break the tooth, the bone, or generally direct force in ways that you're not intending. The more practice you have, the more feedback you get from this. So be gentle. This isn't something you should be working with very hard, but it can generate a lot of force for you. Basically, extraction is all physics. You apply force to one area, and that causes that mass to move in that direction. There are opposite forces, i.e. the bone holding the tooth in place or the shape of the roots grabbing onto something. Those are all things that are happening. So you need to understand what's happening. When you push on it, there'll be a pushback from whatever forces are on there. And after a while, you can really get a feel for what's happening. So when I'm pushing on it, I can tell when a tooth is halfway coming out of a socket. I can tell when there's a soft tissue cuff that's resisting me and I can feel that stretch. I can feel when the bone has fractured off and I'm pulling on that, or I can feel when I'm just stuck in the friction of the bone and it's going there. This might sound weird, but this is something you will absolutely get with a lot of practice, and you'll get a little bit more. Every time you apply a force, the tooth is applying force back on your instrument. So don't be just blindly applying force and wondering what happens. You'll feel that resistance. Now, how can you make sure that you're really getting the force to do what you want? That's gonna be a little bit further ahead. Anyway, stabilizing the jaw is gonna be very important while you're elevating. Basically holding it with a pinch either on the maxilla or firm support with your other hand. When you apply force, you're not just moving the head with that force. If the jaw is still, you're applying force between the tooth and the bone. So with an elevator, you'll notice in this grasp here, the handle of the elevator is in the palm. The index finger runs along the edge of it. In this case, it's acting as a rest. So if the tooth was to release all of a sudden, the instrument wouldn't just keep rocketing up forward. Getting in there and applying force, slow rotational force, and getting that tooth out of there. So in order to elevate, step one, you find a purchase point. So you wedge your elevator in between two hard surfaces, so ideally between bone and the tooth. You apply a force, and then based on what that force does, you adjust the vector of your force in order to get the maximum effect. So don't touch the tooth next door. Some people might say, well, I lean against the tooth next door all the time and it's not a problem. And that's true. Every time it won't be a problem, but sometimes it will be. So it's a good matter of fact to make sure that your elevator is in between the tooth and the bone and not the tooth next door. If you have the bad habit of leaning against the tooth next door, you might have one with large caries or large restoration or something that might be delicate next door, and it might just be your default to lever off that a little bit and break it. So the proper muscle memory of training yourself to never let it touch is going to be the best way of doing that. In order to get a good purchase point, you want to be as apical as possible. You want to get as deep into the bone as you can. If there are caries or broken tooth and you elevate right up a millimeter from the top of it, you're likely to just chip that off. And now it's going to be really hard to get a purchase in because you've now sheared off the tooth structure right at the bone level. So before you apply any force, get as apical as you can so that you've got good solid tooth structure for you to elevate on. So on apex to crown, you want to be as apical as possible. You also would like to be as lingual or palatal as possible when you're coming from the buccal aspect. If you are in the buccal aspect, your vector of force doesn't necessarily push you in the direction that you want it to be. So we take a look at the tooth right here. I'm sure this tooth was just a picture for a resto, but we're going to pretend that tooth needs to be extracted. We want to go nice and slow while we're applying our force. We want to keep the elevator in contact with the root. I fuse it there. I weld it there. I do not let that elevator leave the root and just spin. Otherwise, I can cause myself a little groove in the bone, which can make it much harder to get out of there. So if I was to get this elevator, and this black bar is representing an elevator, if I put it right in this area where there's a V in between the two teeth in that embrasure, and I rotate my instrument, I apply force laterally, but it hits it at a 45-degree angle. And what does this do? This pushes my instrument away. So I didn't do anything to push the teeth, which is what I want to do with my elevator. So you want to be aware that if you don't get that elevator into the middle part where there's two flat surfaces in between the tooth and the bone, and we're not in that V, you're not going to get the vector force applied in the right direction. If I get my elevator pushed all the way forward, and now I'm applying force, it will push that tooth straight in this direction. Now, this is what I was talking about earlier. So this is the maxillary pinch grasp. It's a technique to hold onto the jaw. In this case, there's a forcep in hand, but I use that same grasp when I'm using the elevator. My most important thing is whether I have my index finger or my thumb on the palatal aspect, it is never directly opposite the elevator. If I've got my hand in there and all of a sudden I slip, my elevator could puncture my finger, and obviously that's not ideal because you've now gotten their fluids into you, and if they've ruptured your skin, when you pull that back out between the embrasure, you're now introducing your blood into them. So make sure that you're either anterior, posterior, or even on the occlusal surface so that you can feel what's going on. Sometimes I like to take my thumb and I like to put it right on the occlusal surface in between the two teeth, and I can feel a little bit of space generating between the two of them. So I get a little bit more feedback that way as to how effective my elevation is being. Or in this case, the fingers will go over the roots so that when we're working with the forcep, we can feel whether the roots are moving within the bone or they're about to break the bone or whatnot. For the mandible, it's a very similar thing, whether you're elevating or you're using a forcep. The fingers on one hand are under the inferior border of the mandible. I'm very careful not to push too much force into the soft tissues here. If they're sedated, obviously that's going to push their tongue back and that'll be an issue. If they're awake, it's just going to be uncomfortable. But you've got a nice inferior border of bone on either side where you can get your index fingers underneath, and then you can put your thumb right on the occlusal surface of the teeth. That is going to provide great support for the jaw. Otherwise, if I'm elevating or going with my forcep and the jaw is just bouncing up and down, that is not going to be effective to you at all. So if you're holding the jaw stably, your force will be distributed at the tooth bone interface, which is where we want it in order to get that tooth out of there. And it's going to be much less trauma on their TMJs as well. When I'm working with the lower jaw, I always have the bite block in, whether I'm doing forcep or elevator. And then the patient is aware that they can bite down to relieve some of the pressure. Their masseters pulling and putting some of the pressure onto the bite block instead of the joints can also offload the joints a little bit so there's less trauma. If you're taking a while on the extraction, there's nothing wrong with taking the bite block out, letting them wiggle their jaw around and relax a little bit instead of keeping it open for a very long time with a lot of pressure. We just talked about that. The assistant can also be helpful holding that jaw. My assistants, I don't know if any are logged in today, their left arms get very strong because when I elevate, I'm pulling a lot of pressure, and they're providing support so that it doesn't go at all. I've seen people before hold their chins on the jaws, and then when they push, they're not stopping it from going anywhere. Basically, we don't want to push the jaw closed so that we have no room for surgery. Wherever it is, you just stop it from going down any further. All right, we're going to talk a little bit about forceps. I have a lot of stuff on here. The reason I have it in here is basically as a reference for you guys to use after the presentation is done, so you can access the PDF. I've got stuff for all the different teeth. There's no point in going over them all, but we'll just go over a little bit on the use of forceps, and then you can have the rest as a reference in case you have any questions. Basically, we grab the beaks as apical as we can towards the tip of the roots. And once we do, we fuse all the way from the tip of our elbow to our arm, to our wrist, to our hand, to the forceps, to the tooth. That should now be fused into one piece, and it should all be moving as one, so that the point of rotation is right at the apex of the tooth. I do not want everyone to rotate about the crest of the alveolus, because that's where you can snap roots off. If I keep this tip, the point of rotation, and I'm just going side to side, I'm widening the V of this, which is going to make it a lot easier to get out with afterwards. Once I've wiggled a little bit, I might have generated more space. I will then slide my forceps down a little bit more apical and do it again. Anatomy of the forceps. Basically, this is it. Intrusive forces to start, and I hold the intrusive forces while I go buccal and lingual. If it's a conical root, you can also do rotations to sever the PDLs once you've generated a little bit of space. And you can take the tooth out. All right, so now this is going to go talking about all the individual teeth, and we're going to skip over all this. It's for your reference later. Here we're talking about where the point of rotation is. The higher apical the point of rotation is, the less likely you are to break something. So this is an example of breaking off a root because you had a high point of rotation, too much resistance, and you snap. Maxillary second bicuspids have two tiny little root tips often, and these ones are very easy to break off. So they might not seem that intimidating when you look at them from the crown, but being aware of their root structure, that's something you're really going to want to be careful with. You can see right there, those are easy to break off. Anyone that's taken out a lot of teeth has probably broken some of those root tips off. So I'm going to be a little bit more gentle, and I'm not going to do a rotational force on these ones because obviously they're not cylindrical. But I might be a little bit slower on these. Whether we're elevating or using forceps, bone will stretch. Basically, when you get in there and you're applying forces, there's two phases of movement of the bone. There's elastic and there's plastic deformation. If you're wiggling back and forth really fast, the bone will stretch and go with you, and then it will rebound and it'll come right back to where it started, and you're not any further ahead than where you got. However, if you take your elevator and you apply pressure, or you get your forcep and you just lean it to one side and you hold it there, that bone will slowly stretch and slowly stretch. You think nothing's happening, wait 8 seconds, wait 30 seconds, wait an obscene amount of time, and you'll notice, oh wow, I'm getting a little bit more movement. And then when you let go, that movement has stayed, and now you've got a wider socket where it's going to be a lot easier to get it out of there. So slow, gentle movements over a really long period of time. Like 30 seconds is an eternity in the mouth when you're trying to get stuff done. Try counting in your head and see how long that is. But this is something that's obviously not in your mind when you're trying it most of the time, but it is something that is very effective. Maxillary molars have multiple roots and more likely to be involved with the sinus. Here's some forceps you can use on your uppers. It's there for your reference. People see the ash forcep here on the left side of your screen. It's otherwise known as a bird beak or one with a side hinge on it. I really like that. I use that for basically anything from premolars forward, both upper or lower. The problem with this one is because it's a side action, it's much easier to apply too much force when you torque, and you can break the crown off very easily with it. So if you are planning on using those, be much more gentle than you would consider being necessary until you get comfortable with it. Yeah, mandibular molars with a standard forcep. You can also use COWHORNs on them where it engages the furca. Oh yeah, here's COWHORN up top, and here's an anatomical one as well. The COWHORN is very helpful when the furca is higher or the bone is low, so that you can actually reach in. If you engage the flat surface, I don't know if you can see my mouse or not, but if you engage right, perhaps where the CEJ is right here, and you apply in with the COWHORN, that one point where you're squeezing tight can just shatter the crown off entirely. There should be a slope where it comes down to the furca, and you should be pushing apically. My technique is usually, I use that same grasp that I showed you earlier. I have my index fingers on the inferior border of the mandible, and then I put my thumb on top of the COWHORN to make sure that there's apical pressure, and I'm just gently squeezing, making sure that I'm sliding down and into the furca. If I'm just staying on the same area of the tooth and applying more and more force, that's when I'm likely to break that crown off, and I don't want to do that. So holding it and squeezing it down so that the crown is going down apically as I gently apply force, and then once I have a good handle on it, sometimes the tooth just extrudes straight out, and sometimes it just gives me a really good grip where I can then apply the other vectors of force in order to loosen up and get it out of there. and forceps selection for the molars. I haven't talked about periotomes either. They are not a very fast way of getting teeth out of there. They're basically very thin elevators that you stick down into the periosteum and you use it to widen the socket. There are some that are plain hand-bored and ones that have little hammers, little mallets you can use with them. They are very effective if you think it's a challenging tooth where you might end up into trouble. Loosening it up at the start would be a good idea if you have any handy. All right, ostectomy or doing like a bony trough. Sometimes we have to do that. Now, the whole time we've been talking about how we're going to basically do simple extractions. How do we take these teeth out of there that are just kind of normal? Grab onto them or elevate them out of there. Sometimes we have to remove bone because there's just too much of an alveolus or periosteum holding on to that tooth. What do we do? Well, sometimes you just go to a drill. If I look at this and I say there's no way for me to get this out of there, we might just need to do an aerosol generating procedure. We're going to minimize them as much as we can, but if we can't, we're just going to set up for that. And if I knew that, I would have set up for that ahead of time. Now, other things you can do, Rongeur or hand instrument can also remove a little bit of bone. When I deployed to Haiti on one of the missions of the American ship on Continuing Promise, I basically just took a 301 elevator after raising a little flap with my periosteum, and I just ran it as a ditch on the buccal of the tooth to reduce some bone. And I just gradually shaved it off. Any strong hand instrument is possible to do that. It's not easy, it's not effective, and you got to ask yourself a question: would it really be worth it doing that? Spending my time doing that, having the patient have to put up with that, or would it be better to just go to the drill? So you're going to decide clinically what's got to be done there. A rongeur can also be used to just kind of, if you've elevated the soft tissue, to come down on top of it and grab onto it. You'll see my wonderful art here. The red is where the bone is, and then the soft tissue flap, I would probably just use my periosteal to raise it up a little bit more. And then I can grab a little bit of bone as well and just kind of munch off a little tip right here. And that also gets me a solid grab onto the tooth. And sometimes I'll take the whole tooth and bone out as one unit using the rongeur. Not ideally recommended, but in order to minimize aerosols in an austere situation, that is one thing that you could consider, but I wouldn't consider it a standard technique. All right, now sectioning the tooth. We've also said all along that, yeah, you can just go to a handpiece, but what else could you do besides a handpiece? For the lower molars, I like to use a COWHORN to section my teeth. I usually choose to do that instead of using the handpiece, because sometimes I just take the whole tooth out of there. It surprises me that it didn't love the patient very much and just lets go easy. Fantastic, the tooth's out of there. Otherwise, when I break it, it often fractures off a little unevenly, and then I can grab out one of the roots with that forcep at the same time. So it's pretty efficient. Another technique is that you can use an elevator for that, and we'll talk about that in just a second. So we can see here the COWHORN grabbing on, and it's in the furca, and if you squeeze really tight, sometimes it splits. On the left side of the screen, you can see an x-ray. So there's extensive caries, crowns destroyed. If I can get the tips of my COWHORN down low enough, I can fracture and separate the tooth. Then I can either just elevate the roots out of there, or when I lift apically, one or both of the roots might pop out at the same time. All right, now with an elevator. So this is an obvious example. I could just stick an elevator right down into the furca, snap off whatever connection's left, and then elevate the roots out. You can do that with a little bit more developed teeth, but if I was to try that on this tooth right here, unlikely to be a successful technique. So you gotta know your cases, but often I will complete a section, which was pretty much done already by the caries here, using an elevator. And then you can take out the roots individually, much simpler. Alveoloplasty. Alveoloplasty is not really what most people would consider an emergency. Do you need to do it at the moment, or do you just do the best you can with either closed alveoloplasty, just by getting your fingers on either side on the outside of the soft tissue and squishing it in? Sometimes the bony support allows for that, sometimes it doesn't. If you've already raised a little bit of a flap, you can use a rongeur or a bone file to smooth off those really sharp edges. The rongeur is obviously not going to generate aerosols, but when you're clipping bone, it's not uncommon for it to rock it up and hit you in the face mask or in the scrubs or fall out into the rest of the room. But just be aware that you're going to knock something out of your room, which may be generating some fluid droplets elsewhere. So just be careful about that. Or you just have to come back for a second appointment. And if you need to use the handpiece, you need to use the handpiece as always. If you've already used the handpiece, well, then you've already got it out and you already generated aerosols. So if you've already got that PPE on, why not? Curettage. Now, this is one that I probably see as one of the most common difficulties that new dentists have. I put a few pictures in here. So the picture of periapical cyst or granuloma or whatever it is, we want to get that out of there. Now, what most people do when they grab a curette is they treat it like it's a spoon in an ice cream container. They get the concave aspect and they scrape it along the bottom and they try and scoop out as much as they can. The problem with that is that you leave little shards of tissue all around where it's going to reepithelialize and it's likely to recur. What we want to do is we want to elevate that out of there so that it stays intact, and ideally we just take a little ball of tissue out at the end. So basically what we do is we take the concave aspect, which you can see in the top picture there, and here we have a concave and here we have the convex aspect, and we get the concave aspect and we put it against the bone, and then we slide around in between the bone and soft tissue interface, and we should be leaving a nice clean layer of bone around there. We go all the way around until it's fully freed up, and then we can scoop and lift it out of there, ideally in a whole piece. Do they rip? Yes, but you'll get a much better job cleaning if you keep that concave surface towards the bone. We want to get rid of all that stuff. Irrigation. Normally, I'm also really big on irrigation. I use tons of irrigation. I'll use 30 or 60 cc syringes, and I'll just use multiple once them on the same extraction site. I do it with pressure to dislodge all the little hunks of dust, tooth crumb, bone crumb, bacteria, and everything else that's in there so that I get a nice clean site afterwards. I'm probably not going to be doing the same thing in this COVID environment. Irrigating with pressure is a little bit riskier, so I'd probably be considering that an aerosol procedure if I did it with my little 18 gauge tip and with the maximum pressure my thumb could do. So what I would generally recommend is that you still irrigate, use high level PPE if that's going to be necessary for what you're doing. If there's an infection there and you need to really power wash it, treat it like it's a high risk procedure and just be donned your PPE appropriately. Otherwise, what you could do is you could get a moist gauze. I use lint-free gauze so that I'm not going to leave any little fibers of cotton in there. Moisten it, grab it with your pickups or your hemostat, and then kind of use that to scrub the edges as clean as possible as you can, and then do your irrigation with a little bit less pressure, or just hold your high volume suction right on top of the socket, basically sealing it off, and then you can use a little bit more pressure in that situation. Obviously, whenever we're generating any aerosols, keeping your high volume suction as close as possible is the best. All right, hemostasis, same as always. Gauze compression handles a lot more than you think it would. Just make sure you use your appropriate time. If you want to jam in some hemostatic agents, gel foam or collar plug or whatever, use that as per normal. All right, what complications can we have while we're doing extractions? We can rip soft tissue. I see that one often when people are taking out upper wisdom teeth. They're elevating and they don't realize that there's still soft tissue attached around the cup of the tooth, and they feel movement and they think, oh, the tooth's out, I'm done. And they elevate and the bone's not holding it anymore, but it's still held on by the soft tissue. And as you push that tooth, you make a big rip on the palatal side. So if you do that, stop what you're doing, release the soft tissue from the distal of the 8, which is where it usually is, and then just give primary closure in that area. Other complications, sinus exposure, retained root. We just talked about soft tissue closure. For sinus exposure, if you already know what you're doing, fantastic. If you don't hesitate to refer. Basics you're going to do, sinus precautions. You're going to tell the patient that there's a hole in the sinus or potentially a hole in the sinus. I do not like people going in and suctioning all the way to the other end, pushing up on there, because you can blow through otherwise intact sinus that had a very thin coverage. I do not like people being forced to do a Valsalva maneuver where they blow, because once again, you could have maybe a little hole in the bone but an intact membrane, and you've now blown that out by doing that. So irrigate it out, do your best to see. If you're certain there's a good bony level, good, you're done. If you're uncertain, you can always treat it like sinus exposure. Basically have the patient treat it gently, and it will be better whether there's a hole or not in that area. The sinus precautions are to give to the patient to make sure they don't mess with it. Don't do anything that creates a pressure difference between your mouth and your sinus. I tell my patients mouth and nose because that's something they can understand a little bit better. So if they sneeze and their mouth is open, air comes out their nose and mouth together, no big pressure difference, you don't blow a sinus that way. If they close their mouth to suck on a straw, a vape, a cigarette, or anything like that, once again, that can cause some pressure where it'll pull it out as well. So have them avoid that. If your patient is addicted to tobacco or something like that, this is something that you should talk about at the time of. What can you do to make sure that they don't go straight to smoking? If they say, I'm absolutely going to smoke the second I get out of there, well, you've made them aware, they have an informed consent, they're choosing to do it. If they say, acknowledge that I'm likely to go out and do this, but I'm going to really try and not do it, you can always try and help them out with that. If you've done the program, you can prescribe tobacco patches or nicotine gum or something along those lines in order to help them in that process. If you're not qualified to do so, you can always send them to the pharmacist and have them counseled, because the pharmacist can prescribe that themselves. If the hole is if you do observe a hole and it's under 5 millimeters, that's something you can observe with proper sinus precautions. If it's over 5 millimeters, I would generally counsel closing it. If you don't know how to do it, that's not something that's going to be in the scope of this lecture to teach you, so refer to someone that is competent with that. Now, if there is an exposure where the bone is gone, but you see the membrane's intact, that's good. If the membrane isn't intact, you can now get the bacteria from the nose and the sinus communicating with the oral bacteria, which is a little bit different. So what we want to do is we want to get a little bit of antibiotic coverage to help that close over, to help prevent an issue. And we also want to treat the sinus exposure, not just for infection. So an antibiotic, if they're not penicillin allergic, I'll often use clavulin, 875 BID. You could also use the smaller dosage 3 times a day. Clindamycin's another one that has some sinus coverage. Decide what's appropriate for that patient. I will sometimes give a decongestant. The problem is, if their sinuses get really congested, they're really going to want to blow their nose and clear it, which is going to blow your sinus open more than it already is. I will often give pseudoephedrine. I like 120 milligrams slow release, because you only need to take that twice a day. Otherwise, you're taking it 4 times a day or 3 times a day at various dosages. So I minimize that, and never for more than 3 days. You'll get a rebound congestion that'll be worse. So if they have congestion, the pseudoephedrine's to treat that. I'll often have them take the first one, and then afterwards they can decide if they want to take it afterwards. They're not being forced to take that one. I'm also giving them a saline nasal rinse. If they get any boogers, dried nose, or anything like that in there, I don't want them blowing their nose to clear it. It's okay for them to pick their nose. It's okay to use a moist Q-tip to clear stuff out of there, or you can use a saline spray to really rinse it all the way back and clear that out of there. All right, retained roots. That's another complication that we might come across. If you break a root tip off and you say, I'm going to cause more damage than I am good by getting that out of there, it's okay to leave it there. Not if there's pathology, not if there's an infection, not if you're going to be putting an implant in the site, but there's certain indications where it's better to just leave the retained root in there. You'll see here a little diagram. This is from a British journal recounting the number of retained roots. People tend to have less in the mandible, I think because they're less scared of the sinus, so they're more likely to go after them. And they also postulated that it was most likely right-handedness versus left-handedness, why there was a difference in the maxilla as well. Now, if you can get it out of there, it's best to get it out of there. If not, then you can refer it or observe it. Make sure you tell the patient if there's something there, and make sure you get an X-ray to document it as well. All right.
David.
Sorry, who's talking?
It's Ash. Do you mind if I just throw a little bit in here?
Yeah, please.
So it's a really good point. I'm wondering if, there's no, radiolucency or any type of pathology associated with that root. Perhaps we could say leaving, if you already diagnosed the tooth as vital or irreversibly inflamed, having that diagnosis in advance before you take that tooth out might be a little bit better of a prognosis. If you can't get that out, you're like, okay, well, at least I know the tooth was vital, and I feel a little more confident. I'll monitor it, something like that.
Yeah, so a vital tooth where you leave retained root in is about 70% less likely to have symptoms than another one. So yeah, that's a good prognostic factor there too, for sure. All right, so let's say somebody gets in a trauma, they're out biking to train to stay fit, as the CDS wants us to, and they snap off some teeth at the gum line. We'll call those retained roots. The crowns are all gone. What do you do with those? Well, I mean, you can take them all out, close it all up, do what you want. You could also just do a little bit of pulpectomy. You don't even need to access these teeth. You could just file, do a little gutta perca, and these teeth are preserving the bone for if and when we want to do something else. Or if it was covered, you could always just lay a restorative material right on top of it. Like I believe this one has already been root canal treated, so you could just clean up the top right there, lay some Vitrabond or something like that on top to seal it off, and just leave them there. It's not necessary to get every root out of there, but if you are planning on getting those out of there, just make sure that you're prepared to do so. So here's a couple diagrams. On the left, we're talking about how to use a root tip pick. They're fine tipped. You basically go in there, you get yourself into the PDL space, you widen the PDL space, and you try and hook onto it and roll it out. Pretty straightforward in this picture. Very hard to do in person. That's covered in blood. You might not have good straight line access. You might have poor proprioception. It might be even closer to the sinus. So if it works for you, fantastic. But if you're spending an hour trying to retrieve this thing, maybe you should consider that that's not the best use of time, and you probably shouldn't do so. Here's an example of trying to get in with an elevator into the PDL space. On the right side, the top diagram, this often happens. You break the crown off, or you snap off a bit of the coronal root structure, and now you're in between the bone. It is hard to get into that space. So getting in there a little bit, elevating to widen it, generates a little bit of a V in that area. As you release your elevator, I then push it into that space a little bit, the space I just created. Now I'm a bit more apical, and then I can twist and I can get a little bit better leverage. What I do not want to do is miss that PDL space and be right pushing on the tooth, because that can force it up into the sinus. So be careful when you're going after these, and sometimes the right answer is to leave it there. If I am going to leave a root in there, I'll often give them an antibiotic, but you can discuss with your local surgeon what the best plan is if you end up having to do something like that. Another thing we can do with retained roots, I just kind of threw this one in here, is come in with the pliers or any other elevator. I still tend to use 301 on this. Right there. Enter through the septum with your sharp instrument. You can grab the side of the roots and you can do a cog and wheel rotation, and that root comes straight at the top. Sometimes getting your elevator in this side, there's much less support left by the septum. Sometimes it'll roll back into that direction a little bit easier, because you can see this bone's much thicker and more stable than this side. So I'll either come through here and cut through the bone using my elevator. I like a Cogswell B instead of a Cryers, but that's just preference. Then I only need one instrument in my kit too. And that kind of chips through the bone. And even if I was to just chip and get rid of that bone, septal bone is not going to influence the total socket afterwards. So there's not really a whole lot of loss to getting it out of there. Just make sure you don't leave any chunks in afterwards. But if I can go in and engage this tooth and roll it out, often the curvature of that root follows that path where it wants to come in. All right, so we talked about a lot today. Surgery is a little bit more complicated in the COVID environment just because we can't use the drill as frequently as we'd like to. And irrigation is a little bit more of a challenge. Keep up to date with your science. We're going to be getting updates, I'm sure, every few weeks from CDO. I think we're expecting one soon. And hopefully you got a few little tips and tricks to help avoid generating aerosols. My main one is to just be patient. Slow, gentle, controlled forces generally get the tooth out a lot faster than applying heavier forces for shorter times. Myself, I know Major Carrier is on the meeting as well. Any of the surgeons are more than happy to help you out. Feel free to give us a shout. Reach out to me by email. If you're at home, because this is going up on YouTube, I don't want to put my personal email up here, but send something to my D1 email, and the auto reply is going to send you to my personal email if I'm not in the office. So once again, don't hesitate to reach out to me or any other surgeons if you need any help. We're ready for some questions now.
Well, that was such a great presentation. Let me just take a, thanks so much, Davin, absolutely incredible. I'm just waiting for some questions on the chat here. Some really good points that you brought up and really relevant to COVID, so thank you again. It appears that you have answered everyone's questions before they even thought of them, so